cover about the fundamental difference, how a reverse works, and the three different designs and the rationale behind these changes and how it has evolved really. Okay, so the popularity of a shoulder arthroplasty, the reverse shoulder arthroplasty, can mainly be attributed to the success which it achieved for cuff tear arthropathy, when you have a pseudoparalytic shoulder. But since then, the indications have been extended to involve massive irreparable cuff tears for proximal humerus fractures and the sequelae, even for primary osteoarthritis now. So there's actually a Rhapsody study going on in the UK looking at whether a primary osteoarthritis, whether you do a reverse or a total really, for failed anatomic total shoulder arthroplasties and for tumor reconstruction. So as, for the last 30 years, as we have evolved, it is still an evolution which is going on. We have realized the problems which have occurred with the Gremon type of prosthesis and the tweaks in designs and whether they're improvements or not, that is something time will tell. So to understand the biomechanics of reverse, you need to understand how a normal shoulder functions. So to achieve abduction, the supraspinatus along with the deltoid has to overcome the weight of the arm. Okay, and as you abduct at 60 degrees, there's a rolling motion. So the center of rotation actually changes and then the deltoid takes over. So there's a combination of compressive forces and shear forces. The shear forcing of the deltoid tends to cause proximal migration, and this is normally countered by the anterior and the posterior cuff, and even the biceps to some extent really. So in a reverse, what happens is that there is no fixed center of rotation. So as the humeral head migrates proximally, you lose that compressive action of the deltoid, which would normally occur at 60 degrees because you can't get your arm to 60 degrees. So to counter this, you need to develop something what is called as a fixed fulcrum. So you need a stable point around which the deltoid can actually act to lift your arm up. Now, all the credit goes to Gremon for evolving the reverse shoulder arthroplasty, but the work began much earlier. It began at Stanmore when Jackson Burroughs, he was actually the first to introduce this sort of concept when he used a hip replacement, a constrained hip. This subsequently evolved to the Kessel type of fixed fulcrum prosthesis. I've actually seen follow-ups of some Kessel's prosthesis 25 years down the line and they were still functioning, but I think that would be more of an exception than a rule. And this design evolved further and it's still available in the form of a Bailey Walker shoulder. So what Paul Gremon really changed was, so there were 4 principles. He medialized the center of rotation. He retensioned the deltoid. You provide a fixed center of rotation. And you have a semi-constrained prosthesis which provides a larger arc. So we'll just go through each of these in a little bit more detail. But just a word of caution, a reverse shoulder arthroplasty these days seems to be the answer for everything, but it is a one-way ticket. You get it wrong, there is no real bailout as such really. You can do re-revisions, but you are in uncharted territory really. So the whole idea over here is to provide a fixed fulcrum. So what you're doing over here is the center of rotation which is there. It is medialized in the level of the glenoid. So as such, what happens is this deltoid lever arm is increased. So as you know from simple physics principles in your school days, the longer the lever arm, the less the force. Similarly, what it has done is distalizing the deltoid, so increases the tension on the deltoid, which makes it act more effectively. And this is what it achieves. So it will minimize the shear forces if you are centralizing the center of rotation. And optimizes the vectors which is available for effective functioning of the deltoid. So if you compare the Gremon prosthesis with the original fixed fulcrum prosthesis, it increases the arc of rotation. Okay, so you get more movement there. It provides better tension and the center of rotation. Again, as I said, here you've got your center of rotation which is more lateral. So the shear forces are quite significant. So though you have lateralized and the deltoid over here, all the forces are transmitted at the implant bone interface, which will result in a loosening. And by centralizing the center of rotation, you're minimizing the shear forces over there. By distalizing the prosthesis, so you can see over here, this is your conventional fixed fulcrum prosthesis, but with the Gremon type, it distalized it, so you're increasing the tension on the deltoid. And if you look at the stability, lab studies have shown that a reverse arthroplasty in about 90 degrees of abduction is 2 or 3 times as stable as a conventional total shoulder replacement. And that is because the diameters, the radius of curvature of both the glenosphere and the insert is similar. So there's maximum bone contact, so it can tolerate significantly more joint forces. So there's this concept of deltoid wrapping. So if you look at a conventional, a native shoulder, you've got your center of rotation in the humeral head. And the deltoid wrapping is effectively more of the anterior deltoid and mainly the middle deltoid. So posterior deltoid acts mainly as an extensor, and it's this part of the deltoid which acts as your abductor. Now, what you're doing with the reverse, because you're centralizing the center of rotation, you're recruiting more of your deltoid, which can effectively act as an abductor. So even the posterior deltoid is recruited to act as an abductor. So this is sort of summarizing Gremon's innovation. So if you moved your center of rotation more medially, so that's providing, and you have distalized and lateralized the deltoid. Now, obviously, for everything you come up with, there is a flip side. So what has happened with the Gremon prosthesis, we have noticed that as you have done this, you have had problems with notching, okay? And effectively, it can sort of progress to glenoid loosening and that. And the other thing which is done is you tend to lose your external rotation because the tension on your rotator cuff is less, because as you medialize the center of rotation, both your anterior and posterior cuff becomes more lax, really. So to counter that, there have been evolutions in the prosthesis, and we'll sort of deal with each of them in some manner. So these are your sort of learning curves. So to counter this notching, it was suggested that you place your metaglen more inferiorly, so that will prevent the notching, and sort of tilt it as more. Now again, this has a flip side as well, because as you distalize this, you're going to put more tension on your on your deltoid. So more tension on your deltoid equates to more pressure on the acromion, and so you're more likely to get an acromial fracture. More tension on the deltoid means you're more likely to get deltoid fatigue in the longer term. So, it is a balance of everything which is going to come into play. If you want to tilt it inferiorly, it does mean you're reaming off more bone from the glenoid, which you again want to try to avoid, considering that if you have to do anything in the future, you've got less bone stock really available. So Frankel designed his prosthesis in '97, taking in mind that notching was a major problem. So what he decided is that let's bring the center of rotation a little bit more laterally. Okay, but again, on the flip side, that will impart more shear forces at the implant and bone interface. So technically, the loosening is less. The second change which was there is the cut over there. So, the Gremon prosthesis had a neck shaft angle of 155. So this he cut to 135. So if your cut is more vertical, there is less chance of notching. So further evolution went with the Equinox, where it was not only that they decided to bring the center of rotation more medially again, so the offset there is minimal, just about 2 millimeters. The cut is again sort of midway between a Gremont and an Encore prosthesis, which was the Frankel design. And the big change over here was lateralizing the humerus. Okay, so when you lateralize the humerus, you're again recruiting even more of the deltoid, and you're distalizing the humerus even more. So that will put more stresses on. So these are your three main types available. Medial glenoid, medial humerus, medial. So looking at just their characters, this has a 0 millimeter offset. This is the original glenoid. This is your Encore, which has a 10 millimeter lateralized center of rotation, and the Equinox, which is 2 millimeters. And looking at each of them, how much bone cut is lost. So the maximum bone you lose volumetrically is with the Grammont type, because though you take minimal cortical bone away, it is an inlay type of a prosthesis. You're taking a lot of cancellous bone away. So of the three, the least bone is taken away by the Equinox type. Again, with the glenoid reaming, the maximum contact is with the lateralized one, which is the Equinox type. And again, the purchase, which is a case. So you've got this cage type of prosthesis, which it actually integrates into the glenoid. Surface contact, again, is maximum with the Equinox type. We'll skip this bit. Muscle elongation, sort of, I mentioned briefly. So with the lateralized, the muscle elongation is better. So deltoid activity is most effective. But on the flip side, more the tension, earlier the deltoid fatigue, more stress on the acromion, higher acromial fractures. So this is actually just sort of summarizing each of the styles which I've actually spoken to you all about. So as I've mentioned, this is an evolution. So there is no perfect prosthesis. So if you do one thing, you are compromising on the other. So it's finding the right balance, and that is something which we will still know over the next years to come. This thing I should probably emphasize, because we are seeing more and more of this where you have a more medialized glenoid. So to counter this, if you are going to use your conventional prosthesis, you'll realize that all three prostheses, there'll be considerable laxity on the anterior and posterior cuff. So it is quite important to balance this, and that would be to bring the center of rotation more laterally, either by using a bioreverse, using a bone graft, or using a larger glenosphere to lateralize it.